Thank you all for joining us for our SICSS-Howard Mathematica Funded Alumni Research in Progress Roundtable. During these Real Talk Roundtables, our hosting organizations, Howard, Mathematica, and SICSS, discuss the experiences of people of color within their institutions or offer tips and tricks for success. In the case of our SICSS panel today, teams who receive SICSS-Howard Mathematica Excellence in Computational Social Science Research Awards will be presenting their research projects in progress. They are Ph.D. students, early career faculty, and postdocs who attended SICSS-Howard Mathematica site and were successful in getting funding. They are currently where you want to be. I would recommend you learn about their projects, listen to their trajectory, and ask them questions so you can create a project that gets you funding this year from us and also throughout your career. Participants at the SICSS-Howard Mathematica site will have a chance to ask questions about their projects and get to know them during the second day of Praxis to Power. For now, I encourage you to settle in, listen, and learn.
Hi, everyone. We are presenting on our project, which studies the effect of paid family leave on the health of immigrant parents and children of immigrants in the United States. And we are Nayantara Biswas, Renee Clarke, Susana Quiros, and Bing-Jie. Next, please. So to give you an overview of our talk, we are going to first to discuss the why we are investigating paid family leave for U.S. immigrants. Then we are going to discuss our hypothesis, which is that paid family leave may impact groups differently. And we also discuss the data that we're using, which is a National Health Interview Survey. Then we are going to talk about our next steps, which are writing and submitting a restricted data center proposal. Then we are going to talk about how we are navigating this RDC proposal writing process, and finally, the challenges that we are experiencing. Next.
All right, so why PFL? Why is that important? So PFL is paid family leave, and this helps workers meet personal and family obligations while working. So in the United States, as you can see in the figure to the right, is the only high-income country not to provide paid family leave. So only 11 states, as you can see as well, have paid family leave laws. And PFL has been shown to have a major effect on maternal and child health outcomes. So lack of paid family leave has been shown as to be a huge system levels driver in worsening maternal and child health outcomes. All right, so as you can see here as well, when looking at the United States, when compared to other high-income countries, this is data as of 2021, the United States unfortunately has and continues to have the highest rates of maternal mortality outcomes. The rates increased. So in 2021, as of this past March, the rate is 32.9 per 100,000, which jumped up from 23.8 in 2020. So it is steadily increasing, and definitely need to do something about that.
So the Family Medical Leave Act of 1993 currently stands as the only unpaid federal policy that provides employees with the opportunity to take up to 12 weeks of leave, provided they meet certain eligibility criteria. So this criteria include being employed by a covered employer, having worked for at least 1,250 hours during the 12 months preceding the leave, and being based at a work site where at least 50 employees are employed within a 75 miles radius. However, studies shows that individuals with low socioeconomic status are at a disadvantage because they do not meet the criteria for the Family and Medical Leave Act. Among citizens who often have limited work flexibility, the lowest uptake of paid family leave is observed, which resulted in many of them being placed in the lowest income group. Next slide, please. So in the literature, the studies show the following. The paid family leave is associated with higher rates of breastfeeding and better maternal mental health in the United States. And parental leaves, paid leaves associated with low infant mortality, higher birth weights, and immunization in Europe, countries in OECD, and the United States. So due to the low work flexibility and legal awareness, the effects of parental leaves on health remain ambiguous among the immigrants. Therefore, in this study, we try to compare the effect of parental paid family leave on immigrants with the effect on the US-born parents.
So our main research question we're asking here is that what is the effect of paid family leave policies on immigrant parents' health, both mental and physical? So here we observe self-rated health, psychological distress, and obesity for the immigrant parents. And for the child of these immigrants, we're examining mental health indicators as well as their birth weights. Next slide, please. So our proposed method is going to be an event study where we utilize 3 sources of variation. So our first source of variation is going to be looking at the state paid family leave policy. So here we're going to place the states with a current paid family leave policy as a treated group and the states without a paid family leave policy as a weighted control. Secondly, we're going to be using the timing of this paid family leave policy. So for instance, for California from 2004 onwards, since they have a paid family leave policy, they're going to be part of the treated group. Whereas for a state like Massachusetts, they'll only be part of the treated group from 2019 onwards. Our third source of variation is the most important one, where we examine immigrant status. So foreign-born individuals in the United States would be considered as treated because, as Bing-Jie said, in our hypothesis, those are the ones with the lowest level of work flexibility, placing them in the lowest socioeconomic status. Finally, we will combine all of these 3 sources of variations so that we can compare immigrant parents to US-born parents in different states over time. Next slide, please. So our data collection method is going to be using the NHIS, the National Health Interview Survey, which is a repeated cross-section collected by the National Center for Health Statistics annually since 1963. The health indicators, both physical and mental health, that we use here are publicly available, and these are the self-rated health, the body mass index, the mental health, and the health behaviors for adults, as well as the birth weight of their children. We also use demographic indicators for controls or covariates in our analysis, and these would be the race and ethnicity of the individual, the education of the household, income of the household, age of an individual, sex of an individual, marital status of that individual, and the family size. The reason why we require the restricted data for an analysis is because the public NHIS does not have the following indicators: the place of birth, which will tell us whether an individual is foreign-born or is a US citizen, as well as their citizenship status, because many foreign-born individuals are now naturalized Americans, as well as their state of employment, which will tell us whether they belong to a treated group or to the weighted control. Next slide, please.
Okay. The significance of our project. We believe that it is critical to test whether PFL equally benefits immigrants as it does the general population, because we argue that policies that are not designed with an equity lens may exacerbate disparities rather than reduce them. As Bing-Jie mentioned at the beginning, for instance, the FMLA that restricts the benefits to workers who are employed in firms who have at least 50 employees. And we know that immigrants, particularly Hispanic immigrants, are less likely to work on those type of firms. So we know that there are some elements of these policies that are not designed with immigrants or minoritized groups in mind. And so we may find that these policies may not have the same positive effect on immigrants as they do on the general population. Next slide, please. So our next steps, we are currently writing the RDC proposal to obtain the restricted data set to conduct the study. So basically what we're doing is that we have to come through the NHIS survey code books to select the variables that we need for the study across multiple years, beginning in 2000 and all the way to 2020, I think, or 2018. And so we have to put them on a big file, on a big Excel file, where we make sure that we select the correct variables and that they are given to the and NCHS in a proper format, and this takes a lot of time. So that's one of the biggest challenges that we are also facing right now. Next slide, please. So one of the biggest, and in addition to these, which is a really big project to do what I just mentioned, the next challenge is time management. We all have different constraints that have challenged us to find the time to move this project forward. It has not been easy because again, constraints that are sometimes outside of our control. So it has moved slower than we wanted, but we hope that this summer we will be able to push this project forward and get our RDC proposal ready. And because we are very invested in this project, we all bring different interests and backgrounds, but we are all very interested in maternal health, in the immigrant population, and in policy. And so we are moving this forward. It's just that it has been a bit challenging. Next, and then thank you to our SICSS for supporting our project. We are very grateful to have received your support.
Thank you all for watching. For more information on SICSS-Howard Mathematica, visit our website, follow us on social media, and join our email list.